So good morning all. Thank you chairpersons and the SICOT for inviting me for this talk. My topic is on spinal issues in competing sportsmen.
Can we turn off the lights, please?
So I always remember when I talk with sportsmen about this patient of whom my mentor did almost a few years back. And this was an Indian test leg spinner who went back to his playing ways after the surgery. So Indian sportsmen are special because of these important aspects which makes them good patients for us. They have a high level of primary fitness, a significant strong will to return to function, willingness to do the aggressive rehab needed for the same, and relative short-term lifespan of a sportsman makes this a little bit easier for us. But sports injuries are all the more threatening as well. And especially in India, most of the sportsmen, they are a little bit less aware of injuries except when they have one. So that's what we are going to highlight today about spinal issues in sportsmen. You ask what's different in sportsmen? Actually, pathology-wise, there's no difference in sportsmen. You have to treat it similar to all the general population, except that you have certain bearing, you have to have certain bearing in mind that time is important in these guys, and return to function is of paramount importance. So these two factors are very critical whenever you're dealing with sportsmen. And hence, we as treating clinicians, physicians need to be aware of this, be sensitive to these needs of the athlete. Most people who come with sports guys who come with a problem are cricketers, runners, tennis players, footballers, shooters, archers, boxers, weightlifters, amongst all. And the pathology or presentation is either an acute or chronic presentation in a young sportsman or in a sort of an adult sportsman as well. The major issues which as a spine surgeon we face are facet strains, disc injuries, disc prolapses, stress fractures, discal instability of the spine, and in many cases lysis and spondylolisthesis as well. I'll take you to some examples of few sportsmen having spinal issues. This was a 40-year-old test batsman, right-sided neck pain, significantly painful batting stance, acute onset, really significantly less what you can see on an MRI. Looks clean on an MRI, but on parasagittal cuts, you see there is a facet increased fluid in the facet space at this 3-3-4 on one side. It generally settled with local heat modalities, rest, and some amount of taping to his neck. So the lesson learned is there is always a cause. Try to find out the cause. MRI shows a right-sided soft disc. He was actually adequately treated with rest, some gabapentin or derivatives, do's and don'ts, limited activities, and aggressive rehabilitation later. A nerve root injection was also planned for him. Another example of a test opening batsman, significant acute back pain, no radiculopathy, no leg pain, no red flags per se, had to get back to his games. We did an MRI on him, had an acute high intensity zone which indicates that there's a tear in the annulus of the disc, underwent an epidural and a facet block, was back to the game immediately thereafter. Not so lucky long distance runner who had an acute S1 radiculopathy along with weakness. Plantar flexion plantar flexion weakness in a long distance runner was catastrophic. This guy underwent a microdiscectomy and aggressive rehabilitation following the surgery and was back to competitive running within few months. This was a lucky long distance runner again with a left-sided back pain close to marathon time, and with subsequent investigations had a significant stress fracture which was seen on her left side, which actually needed just the vitamins were low, which actually needed improving the vitamins, and she was completely fine and back to her marathon activities. Another example, left-sided back pain in a fast bowler, and especially on follow-through swing, he used to have the back pain, which used to limit him from his bowling style. Again, an MRI and a unilateral facet irritation hypertrophy was better again with a facet joint injection followed by aggressive rehabilitation. Again, a fast bowler right lower limb radiculopathy, pain on landing. Actually had a smallish extruded fragment of the disc, foraminal impingement on that side, on the right side. Underwent a root block injection, again followed by a rehabilitation. Tennis player, young tennis player with a left-sided back pain affecting his game. Similar facet issue with him, advanced facet strain, facet arthritis, due to recurrent rotatory loading during his shot selection. Again underwent an injection, rehab, had to change his style a little bit during his forehand smashes, and again he was back to his game. Typical under 17 fast bowler, right-sided left, he was a lefty fast bowler. Typical complaints of a right-sided back pain, chronic, sort of getting to a chronicity, not able to bowl even 2 overs because of this pain. Promptly investigated, had a pars fracture on his right side. So mind you, he was a left-handed fast bowler, had an injury on the right side of his pars at L5. Healed with conservative treatment again. After a period of 4 to 5 months, he was again back to his bowling ways. And this was a healing MRI at the end of 5 months. This is a typical problem. And a young athlete who is just growing up the ladder of his athletic career, incapacitated with his back pain, you got to be a little bit careful regarding these. Since he was a bowler, we went into his bowling action per se as well, and had to be changed. The bowling action had to be changed. Since cricket is most common, I'll delve a little bit more on these points, because typically there are 3 sort of bowling actions when you have it. Either it's a side-on action, it's an open action, or somewhere in between. Okay? A side-on action is when your landing foot, the behind foot, when it lands, what is the status of your hips and what's the status of your shoulders? If they are in collinear, you're okay. All these 3 actions, if you see the landing foot, the hips and the shoulders, they're approximately in the same plane. Similarly here, this is a front-on action. Most of the West Indian bowlers bowl with a open-chested or a front-on action. The landing foot, the hip and the shoulders, they are in the same plane, or somewhere in midway also. Most of our Indian bowlers are in midway, where the foot points a little bit towards the one direction, but at the same time, the hips and the shoulders are collinear. So this is a good bowling action, less strain on the lower back. As against if you have anything variation from this, it's a difficult bowling action. So if your landing foot is pointing towards one direction, your hip is again in the same direction, but your shoulders are in different direction while bowling, that puts a strain on the lower back. So both these actions, it put an extra strain on the lower back, and that causes problem and significant amount of back pain, and hence bowling action is more critical. As I like to say, keep the hips and shoulders in line, you'll be fine. If you twist the back and the shoulders, and the back is going to crack. So that's more important for this young bowlers, especially not the bowlers who have toned their bowling action, but youngish bowlers, an amateur spine which develops, it puts extra strain on the lower back, and hence more probable cause of a lysis. So etiology is, all these are repetitive micro injuries. Okay, they happen on a young skeleton, a repetitive micro injuries clubbed with a faulty action, you have a recipe for a disaster. Early diagnosis happens by a fat saturated MRI. The clinical approach, obviously, go through the whole of X-rays, CT scan, MRIs, do whatever to get a diagnosis in these young folks. A SPECS bone scan is a advanced modality which tells you whether there is a hot spot or a cold spot, and it can help you with, find out the hot spot. If it's a hot spot, you can treat it very well conservatively. If it's a cold spot, which means that the bone is more sclerotic, you got to deal with it differently. Active lysis most oftenly heals with bed rest and taking the patient off activity of contact sports. CT MRI locate or define the hotspot. MRI also tells you some additional information regarding the status of the disc below the lysis. What's the status? Because that's most commonly the pain generated as well. Source of back pain. If there is a lysis, an acute lytic crisis also gives rise, but most commonly is the disc which is the culprit. The disc below the lysis is a culprit, and the painful disc below the lysis causes significant amount of back pain in these folks. You got to monitor these guys because they're more prone to progress, and lysis can lead to later listhesis and spondylolisthesis progression. And it depends a lot on what's the degree of initial slippage and what's the posterior element dysplasia is there in the athlete. Management wise, so bone scan throws you an option. If it's a bone scan or SPECT CT shows a hot spot, you can very well tell that this is an acute fracture, is going to heal with time. You're going to take the athlete off all contact activity for at least 6 weeks and gradually start off with light contact activities after 6 weeks and an aggressive rehabilitation of these patients. If it's a cold spot, look for the disc below the lysis. Cold spot, look for the disc below the lysis. If it's a degenerated disc, you might give in an option of a smilar fusion later on. If it's a normal disc, you can proceed with a fusion of only the fractured part of only the lysis lytic area only. If it's of any semblance, even Sachin Tendulkar had significant spondylolysis, and with advanced fitness, advanced treatment modalities, he actually passed off with his, overcame his spondylolytic back. There can be no substitute to a good, systematic, progressive, guided, tailored rehabilitation program to a lysis. To the extent that this is a machine-based rehabilitation, a machine-based analysis of how your back muscles score on a machine-based analysis. So whatever the below average groups are there, you need to concentrate a lot on these below average group muscles, strengthen them to an above average or at least a normal level. And there can be no substitute for this aggressive rehabilitation of an athlete who has backache. Take-home points I would like to conclude, like, these guys are special. One needs to be aware and sensitive to their needs, and especially the time frame is critical for these patients. Treatment principles by and large remain the same, but you got to raise the bar regarding time management and returning back to the function to as normal, as full a function as possible. Use everything at your disposal to get to a diagnosis. Use everything, all modalities to arrive at a diagnosis. Then only you can look forward and treat these patients correctively. And always resist an temptation to overtreat this, especially surgically. Most of us try to finish all the options, conservative options, prior hand, before you think of giving surgery as an option to these patients. Rehabilitation, as I can tell you, the rehabilitation is the key for these group of special people. Thank you.